Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. Today, we will begin our first video on thalassemia. In today's video, we'll be discussing an important type known as beta-thalassemias, but before we start we'll discuss the definitions and history of thalassemias. Let's dive in. In 1925, Cooley and Lee first described children exhibiting anemia, splenomegaly, hepatomegaly, and distinct facial features, later recognized as untreated beta-thalassemia major, commonly known as Cooley's anemia. Autopsy studies conducted by Whipple and Bradford shed light on the condition's prevalence in individuals of Mediterranean descent. This led to the term thalassic anemia, which was later changed to thalassemia. In the 1940s, genetic research revealed the severe course of thalassemia major in homozygous patients, as well as milder anemia in heterozygotes, known as thalassemia minor. In the 1950s, scientists also discovered thalassemias affecting alpha-globin chains. Thalassemias arise from reduced or absent synthesis of specific globin chains in hemoglobin. Mutations in hemoglobin genes lead to a wide range of clinical outcomes, from no anemia to severe consequences, even death in some cases. Hemoglobin A, alpha-2 beta-2, is the primary adult hemoglobin. Mutations affecting the alpha or beta-globin gene result in an imbalance in the alpha to beta chain ratio, leading to reduced hemoglobin production and damage to red blood cells or their precursors, causing premature destruction. This exacerbates anemia and makes some forms of thalassemia exceptionally severe. Epidemiology. Thalassemia's impact is widespread, with approximately 5% of the world's population carrying clinically significant mutations for a hemoglobinopathy or thalassemia. Each year, an estimated 56,000 infants are born with thalassemia major. Thalassemia is found worldwide, but it is highly concentrated in a region known as the Thalassemia Belt. This belt stretches from the Mediterranean through the Middle East and India to Southeast Asia and Northern Africa. The carrier frequency of beta-thalassemia varies across different regions. Higher rates are observed in places like Sardinia, Cyprus, Greece, ranging from 6% to 19%, India, Thailand, and Indonesia, ranging from 0.3% to 15%. Similarly, the carrier frequency of alpha-thalassemia also varies considerably. Cyprus has the highest carrier frequency in Europe, 14%, while eastern Saudi Arabia, parts of Asia, and Africa show rates of 50% to 60%. Certain groups in Nepal, India, Thailand, and Papua New Guinea even reach carrier frequencies as high as 75% to 80%. Interestingly, the distribution of thalassemia coincides with areas where malaria is prevalent. Studies have shown that thalassemia minor, heterozygous thalassemia, may provide some resistance to malaria. Populations with severe malaria have consistently shown a lower incidence of thalassemia compared to those without malaria. While the protective effect is not fully understood, it may be linked to defective parasite growth in affected cells and increased phagocytosis of infected cells. Geographic distribution and case control studies support the idea that thalassemias play a protective role in promoting resistance to malaria in regions where the disease is endemic. Genetics of globin synthesis. As discussed before, the hemoglobin molecule consists of 4 globin chains, with 2 types, alpha-like chains, alpha or zeta, and beta-like chains, beta, gamma, delta, or epsilon. These combinations give rise to 6 normal hemoglobins, each with specific functions at different stages of development. On chromosome 16, we find the alpha-like globin genes, which include 3 functional genes, HBZ, HBA1, and HBA2. These genes orchestrate the synthesis of alpha-like globin chains. Meanwhile, chromosome 11 houses the beta-like globin genes, containing 5 functional genes, HBE, HBG2, HBG1, HBD, and HBB. These genes are responsible for the synthesis of beta-like globin chains. The genes are expressed in a precise developmental sequence. During the first 2 months of gestation, embryonic zeta and epsilon chains are expressed, forming embryonic hemoglobins like hemoglobin Gower 1, hemoglobin Gower 2, and hemoglobin Portland. Around 10 weeks of gestation, a significant shift occurs, and fetal hemoglobin starts to form. Gamma chains combine with alpha chains, creating hemoglobin F, which plays a crucial role during fetal development. At birth, another crucial switch takes place, leading to the formation of adult hemoglobin. From this point onwards, hemoglobin A becomes the predominant hemoglobin throughout life. The genes for globin chains are duplicated, and an individual inherits one cluster of functional genes from each parent. A normal genotype for beta chain synthesis is designated as beta/beta, while a normal genotype for alpha chain synthesis is designated as alpha-alpha/alpha-alpha. Additionally, interspersed between the functional genes are pseudogenes, designated by the symbol C, whose purpose is not fully understood. These pseudogenes add complexity to the process of globin synthesis. Categories of thalassemia. Thalassemias are classified into two main types, beta-thalassemias and alpha-thalassemias, each involving specific gene clusters. These genetic disorders lead to reduced production of crucial globin chains in hemoglobin. In beta-thalassemias, the beta-globin gene cluster on chromosome 11 is affected, resulting in reduced production of beta chains. The severity of the deficiency depends on the specific mutations involved. Some mutations cause complete absence, beta+, while others lead to partial reduction, beta+, of beta chains. Some may even cause minimal reductions, resulting in mild or silent clinical states, beta-silent. Mutations in the delta or beta-globin genes can also lead to the absence of delta or beta chains, delta-beta-0, resulting in the absence of hemoglobin A and hemoglobin A2. On the other hand, alpha-thalassemias are caused by deletions involving the alpha-1 and or alpha-2 globin genes on chromosome 16. When there is a deletion of either the alpha-1 or alpha-2 globin gene, it is referred to as alpha+. This results in decreased production of alpha chains from that chromosome. In contrast, alpha deletion of both alpha-1 and alpha-2 genes is indicated as alpha-0, leading to no production of alpha chains from that chromosome. Non-deletional mutations in the alpha-globin gene, less common, are designated as alpha-T. Thalassemias are complex disorders with diverse genetic causes. It's essential to recognize that individuals with similar clinical presentations may have different underlying genetic mutations. Now you may wonder, what are the genetic defects causing thalassemia? Thalassemia is caused by a variety of genetic defects, including single nucleotide mutations, small insertions or deletions, and even larger deletions. These defects disrupt the normal production of globin chains, leading to thalassemia. The mechanisms behind these genetic mutations are diverse and can interfere with globin chain production in various ways. Some mutations affect the transcription of messenger ribonucleic acid, mRNA. They can target the promoter region or initiation codon of a globin gene, or impact polyadenylation sites that affect mRNA stability. Other mutations can cause errors during mRNA processing, such as adding or removing splice sites. These changes result in either no globin chain production or altered globin chain synthesis. Translation errors can also occur due to mutations that change the reading frame of codons, known as frameshift mutations. Additionally, mutations can substitute incorrect amino acid codons, called missense mutations, or introduce premature stop codons, known as nonsense mutations. Conversely, some mutations can remove stop codons, leading to elongated and unstable mRNA that produces dysfunctional globin chains. In certain cases, one or more globin genes may be deleted entirely, resulting in the absence of the corresponding globin chains. All of these diverse genetic mutations ultimately lead to a reduction or lack of synthesis of specific globin chains. This disruption in globin chain production is responsible for the various thalassemia syndromes that we see. The clinical effects of thalassemia arise from two main factors. Thalassemia causes a reduction or absence of specific globin chains, which are vital components of hemoglobin. This decreased production leads to a decrease in hemoglobin synthesis, resulting in microcytic and hypochromic red blood cells. Additionally, thalassemia causes an uneven production of alpha or beta-globin chains, creating an imbalance in the alpha to beta chain ratio. This imbalance has a significant impact on the survival of RBCs and their precursors. The severity of thalassemia is primarily determined by the degree of alpha-beta chain imbalance. This imbalance greatly affects the lifespan of RBCs. However, it's important to note that the mechanism and extent of shortened RBC survival differ between beta-thalassemias and alpha-thalassemias. In beta-thalassemias, the shortage of beta-globin chains causes RBCs to be less stable, leading to their early destruction. On the other hand, alpha-thalassemias result in an excess of alpha-globin chains, forming unstable aggregates that impair RBC maturation and survival. Mechanisms in beta-thalassemias. In beta-thalassemias, the excess, unpaired alpha chains come together, forming inclusion bodies within developing red blood cells. As a consequence, oxidative stress wreaks havoc on cellular membranes. The cellular damage triggers apoptosis, programmed cell death, of the damaged RBC precursors. Witness as activated macrophages in the bone marrow step in, phagocytizing and eliminating these apoptotic RBC precursors. Further complexities unfold as iron accumulates in RBC precursors, accompanied by inflammatory cytokines, leading to a process called ineffective erythropoiesis. This results in premature death of RBC precursors within the bone marrow, where the struggle to produce enough viable RBCs into circulation begins. As a consequence, the released cells, burdened with inclusion bodies, face rapid sequestration and destruction by macrophages in the spleen, ushering in extravascular hemolysis. Witness the silent initial phase, where individuals with severe beta-thalassemia show no symptoms during fetal life and the early months, thanks to the predominance of fetal hemoglobin, HbF, alpha-2 gamma-2. Yet, between 6 and 24 months of age, after the gamma to beta switch, symptoms finally emerge. But nature doesn't give up easily. To counteract the reduced expression of the beta-globin gene, the gamma, and or delta-globin genes rise to the occasion. Alas, in cases of beta-thalassemia major, the increase proves insufficient to correct the alpha-beta chain imbalance. Now, prepare to be amazed at the bone's adaptation. Severe anemia triggers the kidneys to produce more erythropoietin, stimulating extensive yet ineffective growth of red blood cells in the bone marrow. If left untreated or inadequately treated, brace yourself for significant changes and deformities in the bones, a delicate dance between expansion and depletion, with increased fracture risks. Radiographs of long bones in children unveil fascinating patterns, a lacy or loosened appearance, while skull radiographs reveal a unique hair-on-end appearance with vertical striations of bony trabeculae. Marvel at the characteristic facial features that often accompany beta-thalassemia, prominent forehead, cheekbones, and upper jaw. Witness the spleen and liver, enlarging due to extramedullary erythropoiesis, a process where the overproduction of blood cells outside the bone marrow takes place. This enlargement can exacerbate anemia and lead to reduced levels of neutrophils and platelets. Experience the consequences of excessive destruction of red blood cells and their precursors, a rise in plasma indirect bilirubin causing jaundice. Additionally, discover the increased risk of thrombosis faced by patients with beta-thalassemia. Brace yourself as we unveil the serious complication of iron accumulation in various organs, a potential health threat in adults. In children, excess iron can lead to growth retardation and delayed sexual maturity. But there's more: the risk of cardiomyopathy, liver fibrosis, cirrhosis, and exocrine gland dysfunction in adults. The main culprit behind this iron overload? Regular red blood cell transfusions required in beta-thalassemia major. But that's not all. The excessive erythropoiesis in the bone marrow also reduces the production of hepcidin by the liver, leading to increased iron absorption in the intestines, adding to the iron overload burden. Mechanisms in alpha-thalassemia. Did you know that alpha-thalassemia's impact can be felt even before birth? The reduced production of alpha chains leads to an excess of gamma chains during fetal development and in newborns. These gamma chains combine to form unique hemoglobin tetramers known as hemoglobin BART. As the child grows and reaches 6 months of age, the decreased alpha chain production causes an excess of beta chains. This leads to the formation of stable tetramers called hemoglobin H. Unlike beta-thalassemia, the accumulation of hemoglobin H and hemoglobin BART does not cause severe ineffective erythropoiesis in the bone marrow. However, as mature red blood cells age, the hemoglobin H tetramers may form inclusion bodies, leading to moderate hemolytic anemia in patients with alpha-thalassemia. But that's not all. The anemia in alpha-thalassemia has another contributing factor. Hemoglobin Bart and hemoglobin H have a remarkably high affinity for oxygen, making it challenging for them to release oxygen to body tissues. In cases where all 4 alpha-globin genes are deleted, resulting in hemoglobin Bart formation, severe tissue hypoxia occurs. This can lead to heart failure, massive edema, hydrops fetalis, hepatomegaly, and ultimately, the fetus may not survive in utero or shortly after birth. Dear viewers, join us for an illuminating exploration of the beta-globin gene cluster thalassemias, a fascinating world of genetic abnormalities that impact hemoglobin production. Did you know that scientists have uncovered more than 300 different genetic abnormalities in the beta-globin gene cluster, affecting the beta, delta, and gamma globin genes? These mutations can occur individually or in combination, contributing to the complexity of beta-thalassemia. Interestingly, within specific ethnic groups or geographical regions where beta-thalassemia is prevalent, a small subset of these mutations is responsible for the majority of affected individuals. This regional impact adds to the intricate tapestry of beta-thalassemia's genetic diversity. Individuals with severe beta-thalassemia often carry 2 different beta-thalassemia mutations, a phenomenon known as compound heterozygotes. These combinations of mutations create unique genetic profiles that affect hemoglobin synthesis. To keep track of these diverse mutations, scientists maintain a comprehensive list in the Hemoglobin VAR mutation database, an invaluable resource accessible online. This database helps researchers, clinicians, and families better understand the genetic landscape of beta-thalassemia. Now do you know what is the clinical syndromes of beta-thalassemia? Can you take a guess? Leave a comment and let us know. Don't forget to subscribe, activate notifications, and share this video with your friends. Let's begin with beta-thalassemia silent carrier, the first type in our classification. Individuals in this category show no hematologic abnormalities or clinical symptoms, making it a silent presence in their genetic makeup. Next, we have beta-thalassemia minor. People with this heterozygous state experience mild hemolytic anemia, where their red blood cells, RBCs, become microcytic and hypochromic. However, most do not exhibit significant clinical symptoms. Now, let's delve into the severe form known as beta-thalassemia major. Those with a homozygous or compound heterozygous state face hemolytic anemia, severe clinical symptoms, and rely on regular blood transfusions for treatment. Lastly, we explore beta-thalassemia intermedia. Individuals in this category experience a milder form of hemolytic anemia, along with moderate clinical symptoms. Interestingly, they generally do not require regular blood transfusions. The specific clinical manifestations depend on the mutations in the beta-globin genes and whether one or both of these genes are affected. Some mutations completely halt beta chain production, beta-0, while others lead to reduced beta chain production, beta-1 mutations, ranging from 5% to 30% of normal synthesis. Certain mutations cause minimal reduction, beta-silent. Beta-thalassemia is inherited in an autosomal recessive manner. When both parents carry a beta-thalassemia gene mutation, their child faces a 25% chance of inheriting 2 mutated B-globin genes, leading to clinical manifestations of beta-thalassemia major or intermedia. First silent carrier state of beta-thalassemia. The term beta-silent refers to various mutations in the beta-globin gene that cause only a minor decrease in the production of beta chains. Unlike other forms of beta-thalassemia, individuals in this silent carrier state, beta-silent/beta, have nearly normal ratios of alpha-beta chains and do not display any hematologic abnormalities. The discovery of this condition was made when researchers observed families where the affected children showed more severe symptoms of beta-thalassemia than one of their parents with typical beta-thalassemia minor. Intriguingly, the parents in these families had slightly smaller red blood cells, microcytosis, and normal levels of hemoglobin A2. In some exceptional cases, individuals who inherit 2 copies of the silent thalassemia gene mutation, beta-silent/beta-silent, exhibit a milder form of beta-thalassemia intermedia. This variant is characterized by an increased level of hemoglobin F and hemoglobin A2. Second, beta-thalassemia minor, also known as the beta-thalassemia trait. Beta-thalassemia minor occurs when one of the beta-globin genes is affected by a mutation that reduces or eliminates its expression, while the other gene remains normal, heterozygous state. This condition typically presents as a mild, asymptomatic anemia, with hemoglobin levels ranging from 12.4 to 14.2 grams per deciliter in affected men and 10.8 to 12.8 grams per deciliter in affected women. A peripheral blood film stained with right stain may reveal some variation in red blood cell shape, including target cells and elliptocytes, a condition known as poikilocytosis. The RBCs in beta-thalassemia minor are microcytic and hypochromic, meaning they have smaller mean cell volume, MCV, and mean cell hemoglobin, MCH, values. In most cases of beta-thalassemia minor, the HbA levels range between 92% and 95%, while hemoglobin A2 levels are elevated, ranging from 3.5% to 7.0%. The level of hemoglobin F, another form of hemoglobin, is typically between 1% and 5%. There are less common types of beta-thalassemia minor, such as delta beta 0/beta and delta beta Lapore/beta. These types exhibit their unique characteristics in hemoglobin composition and RBC morphology. Some rare mutations, like Dutch Bet0 thalassemia minor, show atypical features, such as an expected elevation in hemoglobin A2 levels but hemoglobin F levels in the range of 5% to 20%. Another mutation found in a Sardinian family exhibits normal hemoglobin A2 levels. Then we have beta-thalassemia major. Beta-thalassemia major is typically diagnosed between 6 months and 2 years of age when the child's hemoglobin A level does not increase as expected after the completion of the gamma to beta switch. In untreated cases of beta-thalassemia major, the hemoglobin level can drop dramatically, reaching as low as 3 to 4 grams per deciliter. The peripheral blood film reveals significant microcytosis, hypochromia, anisocytosis, and poikilocytosis, with abnormally shaped RBCs, such as target cells, teardrop cells, and elliptocytes. Other abnormalities in the RBCs may include polychromasia, nucleated red blood cells, and various inclusions like basophilic stippling, Howell-Jolly bodies, and Pappenheimer bodies. Surprisingly, despite the severe anemia, the reticulocytes count is only mildly to moderately elevated, inadequately reflecting the extent of RBC production and breakdown. This occurs due to ineffective erythropoiesis, leading to the premature death of RBC precursors in the bone marrow. In beta-thalassemia major, hemoglobin A, the major adult hemoglobin, can be absent or reduced, depending on the specific genotype. If both beta-globin genes are affected, beta 0/bet 0, no hemoglobin A is produced. If one gene is affected, beta plus/beta plus or beta 0/beta plus, a decreased amount of hemoglobin A may be present, ranging from 10% to 30%. Meanwhile, hemoglobin F, fetal hemoglobin, is usually elevated, ranging from 70% to greater than 90%, depending on the genotype and the amount of hemoglobin A. In the bone marrow, there is significant erythroid hyperplasia, with a high number of immature red blood cell precursors compared to myeloid cells. This is reflected in a myeloid to erythroid ratio, which is typically 1 to 20, which deviates from the normal reference range. Due to the massive destruction of red blood cells and the release of free hemoglobin into the bloodstream, the level of haptoglobin, a protein that binds to hemoglobin, is reduced or absent. In contrast, the level of lactate dehydrogenase, LDH, an enzyme found in cells, is markedly elevated. For patients with thalassemia major, transfusion therapy is a vital part of their treatment plan. Transfusions are initiated when the hemoglobin level drops below 7 grams per deciliter and the patient starts experiencing clinical symptoms. Typically, 10 to 15 milliliters per kilogram of red blood cells are transfused every 2 to 5 weeks. To ensure the best survival of donor red blood cells, the transfused units are less than 7 to 10 days old. It's essential to type the patient for major blood group antigens and use antigen-negative donor red blood cells to reduce the risk of alloimmunization, where the patient's immune system reacts against the transfused blood cells. In the mid-1970s, hypertransfusion became a standard treatment for beta-thalassemia major. This approach aims to maintain the pre-transfusion hemoglobin level between 9 and 10.5 grams per deciliter by giving regular transfusions at set intervals. Hypertransfusion serves two crucial purposes: correcting anemia and suppressing excessive erythropoiesis. By reducing erythropoiesis, it prevents the marked expansion of the bone marrow, which can lead to bone deformities. Although hypertransfusion helps manage thalassemia major, it leads to excess iron accumulation in the body. This iron is stored in organs like the liver, heart, and pancreas, causing severe organ damage. To combat iron overload, thalassemic patients undergo iron chelation therapy alongside transfusion therapy. Iron chelators are medications that bind to excess iron and facilitate its excretion. The standard iron chelation therapy involves daily infusions of deferoxamine, administered subcutaneously with an infusion pump over 8 to 12 hours. Researchers have developed oral iron chelators like deferoxamine and deferoprone as alternatives to deferoxamine, improving patient compliance. Iron chelation therapy has been a game-changer, preventing iron accumulation and its complications in thalassemia major patients. Thanks to these advancements, patients now have longer life expectancies and improved quality of life. Hematopoietic stem cell transplantation is the only curative treatment for thalassemia major. It has shown remarkable success, particularly in patients with good risk profiles, leading to an over 90% overall survival rate and about 80% thalassemia-free survival rate. The best chances for successful hematopoietic stem cell transplantation occur when a young patient has an HLA identical sibling as a donor. However, this option is limited as only 25% of patients have a suitable sibling match. Researchers have explored other treatments for thalassemia major. Medications like hydroxyurea have been tested to increase hemoglobin F production and reduce the need for transfusions. While promising for some, it hasn't been effective for all patients. Recently, gene therapy has shown exciting progress in thalassemia major treatment. Successful lentiviral B-globin gene transfer allowed an adult patient to become transfusion independent, sparking hope for a curative option. Clinical trials using lentiviral vectors for beta and gamma-globin gene transfer are underway at multiple sites. Researchers are also exploring gene therapy to increase the expression of the patient's own gamma-globin genes. In the future, gene therapy holds the potential to correct the genetic defect causing thalassemia major, offering a curative treatment option. However, further research and studies are necessary to ensure its safety and effectiveness. Finally, beta-thalassemia intermedia. Thalassemia intermedia falls between beta-thalassemia minor and major, presenting a more severe form than beta-thalassemia minor, yet not requiring regular blood transfusions like beta-thalassemia major. The diagnosis of thalassemia intermedia isn't solely based on hemoglobin levels, but rather the clinical symptoms and features. Hemoglobin levels are typically above 7 grams per deciliter. However, the condition's manifestations can vary widely due to various genetic factors. Thalassemia intermedia is influenced by genetic factors that determine its severity. Some patients may have mutations leading to a mild decrease in B-globin expression, while others may have a combination of mutations causing more significant reductions. In rare cases, a single mutation in one of the B-globin genes can cause significant anemia, known as dominantly inherited B-thalassemia. Additionally, thalassemia intermedia can be influenced by co-inheritance with other hemoglobin defects, further adding to its complexity. Co-inheritance of alpha-thalassemia with more severe beta-thalassemia mutations can result in a milder form of thalassemia intermedia. The presence of athalassemia helps balance the alpha-beta chain ratio, reducing the risk of hemolysis. Combining alpha-beta-thalassemia mutation with a gene mutation that increases G-globin gene expression leads to increased hemoglobin F production. This helps compensate for the reduction in hemoglobin A and corrects the alpha-beta chain imbalance. In some individuals with heterozygous beta-thalassemia, co-inheritance of a triplicate alpha-globin gene locus, triple alpha, can lead to thalassemia intermedia. The excess production of alpha chains creates a greater imbalance of the alpha to beta chain ratio, further shaping the condition's clinical manifestations. Genetic variability in beta-thalassemia intermedia results in a wide range of symptoms and laboratory findings among individuals. The severity of anemia and jaundice depends on the extent of the alpha to beta chain ratio imbalance. Enlargement of the spleen can lead to low platelet and neutrophil counts. Thalassemia intermedia exhibits a diverse clinical course, with some patients experiencing mild symptoms despite moderately severe anemia, while others may face issues like exercise intolerance and pathologic fractures. Even though Thalassemia Intermedia patients do not receive regular transfusions, they can still experience iron overload. Ineffective erythropoiesis reduces hepcidin production, leading to increased iron absorption in the intestines. However, complications like cardiac, liver, and endocrine problems usually appear later in Thalassemia Intermedia patients compared to those requiring regular transfusions. Thalassemias with increased levels of fetal hemoglobin. Thalassemias with increased levels of fetal hemoglobin beyond infancy and into adulthood are a unique group. Let's first delve into the hereditary persistence of fetal hemoglobin, HPFH, where the beta-globin gene cluster often has a deletion in the delta-beta region, resulting in elevated hemoglobin F production. But wait, there's more. In some types of HPFH, the beta-globin gene cluster remains intact, with non-deletional mutations in the gamma-globin gene promoter region also increasing hemoglobin F production. Though individuals with these mutations usually show no symptoms, their condition becomes significant when interacting with other forms of thalassemia or hemoglobin variants like hemoglobin S. Heterozygotes for deletional type HPFH typically have no symptoms, normal MCV, and hemoglobin F levels ranging from 10% to 35%, depending on the mutation. Homozygotes for deletional type HPFH are also asymptomatic, with a normal or slightly increased hemoglobin level, 100% hemoglobin F, and slightly hypochromic and microcytic RBCs. Now, let's turn our attention to delta-beta-0 thalassemias. These conditions involve deletions in both the delta and beta-globin genes, leading to increased hemoglobin F during adulthood. Some non-deletional types of delta-beta-0 thalassemia have also been identified. Individuals with heterozygous delta-beta-0 thalassemia, delta-beta-0/beta, have reduced hemoglobin A levels, normal or decreased hemoglobin A2, and hemoglobin F levels ranging from 5% to 20%. They exhibit a beta-thalassemia minor phenotype, with a slight decrease in hemoglobin level and hypochromic, microcytic red blood cells. On the other hand, homozygous DB0 thalassemia, delta-beta-0/delta-beta-0, showcases hypochromic, microcytic red blood cells, 100% hemoglobin F, and alpha-beta-thalassemia Intermedia phenotype. Now we have hemoglobin Lepore thalassemia, a rare type of B thalassemia caused by a unique genetic fusion. Let's dive right in. The Lepore globin chain is regulated by the less active delta-globin gene promoter, leading to reduced production. On the reciprocal chromosome, known as anti-Lepore, the beta-globin gene remains unaffected, resulting in normal beta chain production. Individuals who are heterozygous for hemoglobin Lepore thalassemia, DB Lepore/B, exhibit a decrease in hemoglobin A and hemoglobin A2 levels, an increase in hemoglobin F, and approximately 5% to 15% HB Lepore. Their clinical symptoms resemble those of beta-thalassemia minor. In individuals who are homozygous for hemoglobin Lepore thalassemia, DB Lepore/DB Lepore, both the delta and beta-globin genes are affected, resulting in no production of hemoglobin A and hemoglobin A2. Instead, they have around 80% hemoglobin F and 20% hemoglobin Lepore. Their clinical manifestations are similar to those of beta-thalassemia major. Screening for beta-thalassemia minor. With the high carrier frequency of beta-thalassemia mutations worldwide, screening for B-thalassemia minor has become a critical aspect of public health. Mass screening programs, coupled with prenatal diagnosis, have already shown promising results in countries like Italy and Greece, reducing the number of children born with beta-thalassemia major. The first step in screening potential carriers of B-thalassemia disorders involves measuring specific parameters. Hemoglobin levels, mean corpuscular volume, MCV, and the levels of hemoglobin A2 and hemoglobin F are evaluated to rule out other causes of microcytic anemias, such as iron deficiency. For couples seeking preconception counseling or prenatal testing, molecular genetic testing of the HBB gene is recommended. This sophisticated technique detects carriers of B-thalassemia and provides valuable information about the specific B-globin gene mutations involved. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.